I request Dr. Apurva. She is having a case of can infectious scleritis extend posteriorly? And after her, Dr. Vishal Prakash.
Good afternoon, everyone. Today I'll be presenting a case on can infectious scleritis extend posteriorly. A 52-year-old female patient came with the complaints of left eye pain and redness since 1 month. So the patient came to the OPD with the complaints of redness, pain and irritation in the left eye 20 days back, and the patient was diagnosed with preseptal cellulitis based on CT orbit findings and was started on oral antibiotics. On constant probing, the patient gave history of lemon tree branch injury in the left eye 3 months back. She also gave history of using mother's milk in the left eye thrice a day for 2 days. The patient was referred back from an outside hospital in view of scleritis and scleral abscess. The patient gave history of worsening of the condition on oral steroid which was started from outside, that is tablet Visalon 50 mg. On general examination, the patient was within normal limits. On ocular examination, the right eye visual acuity was 6 by 12 partial and left eye was 6 by 60. All other ocular findings were within normal limits. On anterior segment examination, the right eye was within normal limits and the left eye showed diffuse congestion of the conjunctiva with scleritis and scleral abscess at 8 o'clock, 5 o'clock position. The cornea showed fresh non-granulomatous and diffuse keratic precipitates on the endothelium, and the anterior chamber showed cells 3 plus and flare 1 plus. The fundus examination of both the eyes was within normal limits. B scan was also within normal limits. On investigation, the leukocyte count was raised. The patient was additionally tested for a TPHA and Mantoux test, which came out to be negative. So the clinical diagnosis of multifocal scleral abscess with acute non-granulomatous anterior uveitis was made. The suspicion of fungal and nocardial infection was kept in view of multifocal presentation. So, incision and drainage for multifocal scleral abscess was advised and the specimen was sent for culture and sensitivity. Post incision and drainage day 1, the left eye showed diffuse congestion of the conjunctiva and incision and drainage sites were seen at 5, 8 and 11 o'clock position, which were healthy with multiple pus points on the inflamed sclera. Rest all findings were same as earlier. On fundus examination on the left eye, it showed far inferior peripheral shallow exudative RD without regma or retinitis, which was confirmed on B scan, which showed left eye membranous echoes of RD present with ST fluid and RCS thickening of 2.49 mm. The left eye fundus image showed inferior serous RD with shallow CDs. On blood agar culture, Pseudomonas came out to be positive and the following sensitivity testing was noted, but polymicrobials were suspected as there was flare-up of inflammation after treatment with oral steroids. On day 3, in view of multiple pus pointing with accumulation and shallow RD, the patient was started on injection amikacin and repeat IND was done. On retina, opinion was sought for left eye inferior shallow peripheral exudative RD and observation was advised in view of partial improvement. On repeat culture, no growth or organism was found, so the patient was continued with IV amikacin BD for 7 days in view of Pseudomonas scleritis, and the patient was restarted on oral steroids on postoperative day 5 with tablet Visalon 50 mg in view of shallow exudative RD. The patient was continued on oral steroid taper with close monitoring. This is the left eye montage image which showed persistent inferior serous RD with shallow CDs postoperatively. At the last day follow-up, after 2 months, the patient showed that anterior segment infection was subsided with healthy incision and drainage site and controlled non-granulomatous anterior uveitis, and the vision was improving to 6 by 24 with clinically improving shallow exudative RD. So the take-home message is that meticulous history is to be taken with multiple debridement should be advised for better globe preservation rates. Response to treatment is to be noted as if steroids are given and if there is worsening, then it may help us to differentiate between infectious and non-infectious scleritis. And corticosteroid can be given safely under antibiotic cover in these patients. And early diagnosis and prompt treatment should be advised.
Very nice documentation. A very good case of infectious scleritis, very nicely documented. well investigated.